Okay, so good morning. Welcome back to the Northwell Health Laboratory. My name's Dwayne Breining. I'm the Executive Director of the laboratory here. I'm here with my colleagues, Dr. Deborah Schron, one of our Associate Directors, and Dr. Greg Berry, who's a Director of Molecular Testing in the laboratory. If some of you remember, way back in March and April when we were doing this on a regular basis, we promised you we'd have something back once we got more of our testing established. And this is that here. We figured it'd be a pretty good time to do it because we've now surpassed 1 million diagnostic tests for COVID. And as you know, some recent news has come out about vaccines, so we can talk about that stuff a little bit and what the future looks like for the laboratory testing here at Northwell and in general. So as I mentioned, we've now done over 1 million diagnostic COVID tests in this laboratory here. That's the molecular tests, sometimes called the PCR tests, that test for the actual virus. In addition to that, we've done over 500,000 antibody tests, sometimes called the immunity test, the test that tests for whether or not someone has antibodies to the COVID, which is evidence that they've had the infection in the past. And by and large, the data seems to indicate that if you have had this infection in the past and you've recovered from it, the chances are pretty good that you're immune to getting it again, at least in the short term. It's not impossible, but the chances seem very good that you're immune to getting a reinfection in a short period. Just want to state, even though in the New York area everything has been calm for a while, our infection rates have been pretty stable. Up until very recently, they've been hovering between 1% and 2% positives of the tests that we're doing. Lately, we've been seeing a little bit of flare-ups in various communities in the city and outside of the city. Our own testing data, we've gone up to a 3% positivity rate in the last couple of days, which is nothing that we can't get under control if everybody's very careful and follows all of the precautions. But it's something we're watching very carefully, and it's something that we have to reinforce due diligence on the social distancing precautions and mask wearing precautions. So we're watching that very carefully. As everybody knows, as we go into the fall season, as the weather changes, people are indoors more often. We're going into the holiday period. We want to be very careful that we don't let our guard down and let this thing flare back up again. And as you know, in the rest of the country, it is still not under control. They're in bad shape in a lot of different areas, and we want to make sure we never get back there again in New York. In the laboratory arena, even though, thankfully, less patients are in a clinically bad situation these days, things have never slowed down for the laboratory. In fact, there's probably more demand for testing now than there was even back in April. So I really want to, shout out the laboratory staff, both the management, the laboratory techs, but also as you go around later today on a tour, you'll see we employ drivers, we employ IT people, we employ client services, communication people. All the people in the laboratory have been going nonstop since back in February and March, responding to this crisis. And that hasn't slowed down for us at all. And especially our phlebotomy teams who go out and meet the patients and take a lot of the swab samples, and also the molecular team that works with Greg here. They've especially been going pretty much around the clock since back in March on this, and they haven't stopped at all. We'll take you around on show and tell a little bit after this. We'll show you Northwell Laboratories has invested over $30 million in getting new machines and technology and personnel in here to keep up with the testing demand. If you look out to the entire Northwell system, we've invested probably over $50 million to get testing at all of our hospitals in addition to this core laboratory. So we've really been ramping up nonstop since back in March. We got great news yesterday on the vaccine front. As far as we know, all of the companies that are developing vaccines have very good preliminary results on both their safety data and their effectiveness data. And we learned yesterday that one of the first vaccines to become available has a 90% effectiveness rate according to the preliminary data. That's a really good rate, and that makes everyone very happy. But even though we're getting that good news, and there's going to be more good news on the vaccine front as more of the developers get through their trials, we have to maintain our diligence and not let our guard down, especially with a place as populated as New York. And like I said, we're going into the holiday seasons, and we're going into the fall where the weather's going to get colder despite the last 3 days of beautiful weather. More people will be aggregating inside. And we have to be careful that everybody wears masks, or this thing could easily flare up very quickly again. So we have to make sure we don't have a backslide there. Like I said, there are some areas of infection uptick going on right now. If everybody follows precautions, we can get that under control. But if people ignore the precautions, we could be entering into a dangerous period, so we want to make sure we're prepared for that. I want to assure everybody that with that investment that we've made and what you'll see in the laboratory later, we are prepared for the worst case scenario. Even though we're hoping for the best, and we're hoping vaccines come out and start getting deployed soon, and I think we'll see the first rounds before the end of the year, it is going to take months and months to deploy vaccination to a level where it allows us to get this under control. So until that time, we're anticipating doing just as much, if not more, testing than we're doing today for the ongoing surveillance. And everybody needs to make sure that they follow the rules about social distancing and wearing masks. And that way we don't let our guard down, even though we're getting good news. So we're hoping for the best case scenario, but we are absolutely prepared for the worst case scenario. So even if we have a resurgence like everybody fears, even if we get back to levels that we saw in April, which we think is pretty unlikely in New York, but we can't let our guard down or that could happen. We are prepared for it in this laboratory and in this health system, and I know the other health systems have been doing the same thing. We're never going to be as unprepared as we were back in February and March for this thing. We are moving into what's traditionally flu season, and as many of you know, the symptoms for the flu are the same as the symptoms for COVID. So patients who come in that are symptomatic and have any of those and see their doctors, they will need to be tested for both COVID and flu. We are prepared. Greg and his team have been ramping up nonstop to be able to do all of the flu testing and all of the COVID testing that we anticipate we'll need, even if we hit the worst case scenario with a bad flu season and a COVID resurgence. Again, we don't expect that to happen. People in New York have been exemplary in infection control precautions, and as long as we keep our awareness up, I think we'll be safe. We look to Australia in the Southern Hemisphere every year to predict what our flu season's going to be. Basically, they have the flu season before we do because of the climate, the seasons being different down there than they are up here. So basically, we can look to Australia, and that predicts what our flu season's going to be. From that data, we're hopeful that we may have a very mild flu season this year. And probably the masking and social distancing plays a big role in that as well. So if we keep up these precautions, hopefully we'll be protected from the flu. But again, if we need to do lots of testing for the flu, we're ready to do that. So we'll be ready to go. This laboratory and other laboratories are going to continue to be part of the infection control surveillance testing. That's already been launched at a lot of colleges and universities and other schools and places of employment. Nursing home workers, healthcare workers are all being tested on a regular basis, so we'll be a key part of that effort going forward. And again, that's going to last until the vaccines get completely rolled out and enough people get vaccinated that we can put this thing back in a bottle. And probably eventually COVID-19 ends up being an illness just like the flu. One of those things that we test for every year, one of those things that when someone comes in with a fever and headache and different symptoms, that it's on the list of things that we need to diagnose or rule out. But hopefully it'll just be another thing that we test for like the flu and another thing that we vaccinate for on a regular basis. Like I said, the news on the vaccine front is very good, not just with the one yesterday, but it looks like all of the vaccines that are being developed thankfully, look like they're safe and look like they're likely to be effective. It turns out it maybe wasn't as difficult to make a vaccine to coronaviruses as we feared it might be. So that's great. But it's very important we don't relax, we don't let our guard down, we follow all of these precautions. You'll be hearing a lot of that on the news. If you're in the city, you hear the mayor talking about it, and you'll hear the governor talking about it a lot. There's a lot of concern, especially as the weather changes and there's going to be more indoor activity rather than outdoor activity, which is it's significantly safer to be outside rather than inside. We need to be careful not to let our guard down just because the news we're getting is good. So even though it looks like things are going to get better, there's light at the end of the tunnel. That's going to take several months, and we need to be prepared for the worst case scenario. We are. Northwell Health is prepared, even if things were to get as bad or even worse than they were back in April. I can tell you that the laboratory is prepared, my clinical colleagues are prepared. We've been doing nothing but preparing for the worst case scenario for the past several months. So we are prepared with additional ICU beds, expansion capabilities, testing capabilities, ventilators, which we hope we'll never have to use, and testing capacity, which we hope we'll never have to use. So even if things get bad, we're ready for it, but we're hoping things will be pretty good. I guess at this point I'm done. I can open it up to some questions, and then we'll take a lab tour. Dr. Schron and Dr. Berry will lead some lab tours. So any questions?
You mentioned worst case scenario several times. What is the worst case scenario?
So the general rule in healthcare, like a lot of things, right, is you hope for the best, prepare for the worst. We never want to be caught as flat-footed as we were back in February when this thing hit us. And I can say with a certain amount of confidence, I don't think we ever will be caught as unprepared as we were back in February. So we consider everything individually. So we look at what's the worst case scenario for COVID. Well, the worst case scenario for COVID is if we got back to where we were in March and April. And we've even gone beyond that. So we've anticipated COVID even being worse than it was in March and April, making sure we have enough beds, enough staff, and enough clinical preparedness to be ready even if it gets that bad. Then we considered flu, which could happen concurrently at the same time. And we said, what if we have the worst flu season that we've ever had happening at the same time COVID's happening? Do we have enough testing? Do we have enough beds? We've been working very hard over the last couple of months to make sure we have enough in to do that, so we're prepared for that. And then, looking at other things that aren't, usually on the radar, but, we had Superstorm Sandy a few years ago, which interrupted the travel, interrupted supply chains. What if something like that hit at the same time? So we used to do something with our inventory for laboratory testing called just-in-time inventory delivery. Basically means you don't keep much stock on the shelves because it costs money to store things. Real estate's expensive. Personnel to manage it is expensive. Well, all that planning went out the window with COVID back in March and April. Because in order to be prepared for the supply chain interruptions that we've had, we make sure that we have stock on the shelf now so that if we have to do testing independently of any supply coming in from the outside, we're confident that we can maintain that for a significant period of time now.
You've also spoken about testing capacity and how the testing capacity has been ramped up.
Mm-hmm.
Just to remind the public, under what circumstances should someone get tested?
Well, certainly anyone who's symptomatic should see their healthcare provider and come in and get tested. We're at the point now whereas different office buildings, different schools, and that get back to work, every individual place is developing its own surveillance and screening program where a certain amount of people are being tested on a regular basis. And I know the colleges have different protocols, the employers have different protocols. So basically, follow the guidance that you're going to get from your leadership at whatever place you're at. But certainly if you think you've been exposed, or if you think you're symptomatic or you might have the flu, go see somebody and get tested. If you're going back to a place of work or business, going back to school or something like that, follow the guidelines that are being released from your leadership at that place.
Well, I know some people who, if they've been in some sort of a mass gathering, maybe not a mass gathering, but a small family get-together or something, they're not feeling symptoms, they may still go and get tested just to sort of thing?
Yeah, I think there's nothing wrong with that. If you've got a concern that you've been in a social situation, and certainly if you've been in a situation where you've had about 15 minutes is the guideline, so 15 minutes of cumulative exposure to somebody, usually in an indoor setting, where they're not your immediate family and you don't know where they may have been and who they may have come in contact with. If you want to get tested in that scenario, I don't think that would be unreasonable.
Dr. Breining, we have a few questions from the live stream. How many tests does Northwell do daily now? How much could it do?
So on a regular basis, and Dr. Berry will correct me if I'm wrong here, I think on an average day, we're doing somewhere between 6,500 and 8,000 tests daily in this laboratory. Occasionally, if there's a high demand, we can pump that up to about 10,000 tests per day. We're looking at new technology where we can even increase that. On a daily basis for antibody testing, Dr. Schron will correct me if I'm wrong, I think we're doing about 2,000 antibody tests per day still. Oh, question in the back, yeah.
Following up on that, how fast do you get those results back?
We use a tiered priority testing system, and we've done that from the beginning here. Knowing that, especially at the hospitals, if you have someone coming in for emergency surgery or labor and delivery, right, having a baby, they're going to need to get tested quickly. So we have testing capability on site at all of our hospitals, which will give people results in a matter of an hour or two. The most rapid test we have will give a good result in about 15 minutes or so. Testing that's done in this laboratory, usually it's in the less urgent sort of outpatient settings. We turn things around in 1 or 2 days. Most of it's done in 24 hours. Sometimes it extends out to 48 hours. And then the lowest tier, for a lot of those patients who don't have a direct exposure like we just talked about, that are, you know, in a kind of a lower guideline, lower acuity group, we'll work with some of our partner commercial laboratories, and that testing will be done there. These days, they're getting almost all of that testing done within 2 days. Occasionally, when there's high demand, especially with what's going on in the rest of the country, that'll extend out to 3 or 4 days. We're trying to keep that to a minimum now, so we'll send the testing to whoever's getting it done most quickly if we can't do it ourselves.
Dr. Breining, another question from the live stream. Can you explain how all the investment in equipment, how that would help or make a difference if we do get a second wave?
Oh, it's basically just increasing capacity. So when we do the tour through the molecular area later, we were very lucky here at Northwell. We already did a significant amount of viral testing and the type of molecular testing that's done for COVID. And we hadn't, at the time this hit back in February, limited ourselves to just one particular testing platform. So we had, I think, 3 major platforms that we were using at that time, all of which we were able to convert to COVID testing and deploy fully for the COVID crisis. Since that time, instead of having, you know, for instance, 2 machines, we now have something like 12 machines. So we can do, you know, 5 times as much testing as we were able to do when we had less machines. And it's just simple mathematics on that level. If you have more machines, you can do more tests.
One more question, which is, there was a problem with turnaround time at times at the height of the pandemic, the first wave. So how does the equation change this time around if there's another spike?
Well, I think both our lab and every other clinical testing laboratory now has significantly more testing capacity than we had back in March and April, where tests were just being newly developed. Reagents couldn't be manufactured enough to be moved out as much as was needed to meet the demand at that time. I think every lab, including our own lab, we can now do 10 times as much testing as we were doing initially on this. The commercial labs have multiplied what they can do even more than that. So even though there's a significant amount of demand nationwide now, the major laboratories that are doing testing at that level can do significantly more testing than they could do before. Plus, all of the medical system-based laboratories like ours have significantly ramped up their testing capability. So I think we're one of the most productive medical system-based laboratory. I think there's only one other medical system-based laboratory in the country, University of Washington, that does as much testing as we do. The commercial labs multiply that by 10 or 100 times. And then there's a lot of smaller medical system and hospital-based laboratories that have also ramped up their testing. So there is a lot more testing capability and capacity in this country than there was back in March and April. So I don't think those prolonged turnaround times are going to repeat again. At the height of the crisis, I think the turnaround time problem got as long as 2 weeks. And obviously, if you're getting swabbed and you have to wait 2 weeks for your result, you may as well not even do the testing because you can just isolate for 2 weeks. And the infection, if you have it, will have run its course. I don't think we're ever going to return to those days because the capacity has been ramped up so much.
You've acknowledged not being prepared for COVID-19. Why do you suppose that was? And I don't, necessarily think that requires a political answer. I don't think it's a political question. But clearly, a pandemic is not something that was unanticipated.
That's right. We saw this coming, and the short answer would be we should have started preparing for testing earlier than we did. There are some international surveillance programs set up specifically to recognize things like this where, other countries may not be as forthcoming with information about the scope of the crisis as quickly as we would like them to. As a result, the U.S. had its own surveillance system set up. It doesn't seem like they were functioning appropriately at the time. The laboratory testing industry is such that in order to develop new tests, you need to go through a very rigorous validation process to validate these tests at each step of the way. And each step in validation requires the results from the previous validation step before it in order to make a decision about how to go forward. So to a certain extent, that rollout is non-compressible in a timeline. So the only way to really make testing available earlier is to start the timeline earlier. And like I said, some of those early warning and early start systems that requires coordination with the early warning systems and the FDA and the CDC did not function optimally at the beginning of this. And that basically delayed us by probably more than a month in starting up.
So it's a surveillance problem that you see primarily?
I think it's surveillance and coordination and rollout. Okay, I think that's it. We'll break into tour groups and we'll go see the lab. Thanks.